Welcome to Cool Life Podcast, brought to you by therealthingdating.com. www.therealthingdating.com.
Polydor Records for out scouting. This girl grabbed my bangs and ran my head right into the speaker.
Oh,
And everyone here like this, yeah.
When we shot the scene in Good Will Hunting, I didn't know who most of these people were at the time. I mean, they weren't stars. It was Gus Van Sant that directed it. Gus Van Sant was on the floor with Matt Damon's character. I didn't even know who Matt Damon was at that time.
I'm Eva John. I'm a former candidate for local government. I was a children's television entertainer, and I love this world, and I believe we should take care of each other and have a lot of fun along the way. Welcome to Cool Life. Here we go. And welcome to Cool Life Podcast. I'm Eva John, and today we have Jeffrey Gelgoot, who is president of Gelgoot Healthcare Consulting, with 20 years in existence for that company and 27 years plus delivering healthcare network consulting to physicians and medical practitioners here in Ontario. Jeffrey, welcome. I'm so glad to have you here.
Thank you, Eva. It's a delight. Thank you so much.
I'm just thrilled, and I'm so happy for you and the work that you're doing. And I can't think of a single more important area of work in our society today. I mean, having come through a pandemic, having discovered, people took a new view on something as simple as getting a flu shot, on something as simple as hand washing as a result. And healthcare has taken on a whole different meaning in recent years. And with that in mind, what do you think locally or regionally here in Ontario, what do you think is the weakest link in what's happening in healthcare in Ontario today?
Well, I think, in fact, I know, it's not so much that I think. Most Ontarians are not aware of the gaps in terms of being able to find appreciable support at the family practice level. At the moment, 5 million Canadians are part of that orphaned patient population that simply don't have access. 3.5 million of those Canadians live in Ontario. And these numbers are staggering, and they're staggeringly high. And one has to ask the question, why are we back to where we were in the 80s? What's happened to the trust that was once established between physicians and the Ministry of Health and Long-Term Care, and where are we now in 2023? What's happened that has hurt or eroded that trust? And so what I would say to you is a huge link right now is getting people, in the urban dictionary, getting them hooked up with family physicians,
Right.
who, of course, are the gatekeepers. And there's horrendous disconnects.
Truly, I'm a person who, uses healthcare and gets the treatment. I think we've all witnessed, it started with the length of time in emergency rooms and various other ways where we see kind of a change, if not a kind of a erosion of the services that we were once used to.
Right.
Now, with that change, delivering healthcare in Ontario, what do you think would be the most important improvement on that issue?
Well, number one is to attract and retain our very bright students who, first of all, have incredible difficulty getting into medical schools, and then catapulting them, once they've done their educations, into the community with absolutely little or no business experience, to take on the role of small business operator, and truly they have no experience whatsoever. And what the the various chat groups that they listen to and where their information is coming from is they're being advised to not even attempt to go into community-based family practice
Really?
because the risks are just too significant and the expenses are through the roof. And most Ontarians really don't have a sense of, gee, my doctor is free to me and I'm entitled to these services. But what does that mean for the doctor? And I think having some context to that would be important for people to understand that, first and foremost, these services are not free. They're paid through the taxpayers' coffers. That's number one. And number two, the patients are really the end users. And so from the time that, let's just say for argument's sake, you're ready to receive a flu shot, there's so many steps involved in getting that flu shot into your doctor's office, from having the know-how and the ability to fill out the forms to the government pharmacy, ordering your flu shots for high-risk patients over 65, ordering your regular flu shots for patients under 65, to ordering the syringes, to ordering the alcohol preps or just the rubbing alcohol with cotton balls, to having the Band-Aids available, and then the infrastructure to load the syringe. And there are so many steps involved in just getting a flu shot ready for the average Ontarian that nobody would ever consider that, holy smokes, somebody had to do that work. And family physicians are paid approximately $10.80 from the provincial government, from OHIP, to make certain that all of those steps are met and to administer your flu shot. And what the average Ontarian doesn't recognize is that the government pharmacy only provides the juice that goes into those syringes. And the physicians have to provide the syringes and the Band-Aids and the cotton balls and the nursing and the office space. And so, the $10.80 that a family physician receives from the ministry to provide that service is eroded by infrastructure costs.
Of course.
And nobody wants to take that risk anymore. The risk is just too significant. And the rewards are not significant enough. And, I'm not here to support, oh, woe is me, doctors are not remunerated properly. But having an in-depth understanding of the doctor's agreement with the ministry for remuneration and what goes into providing services, doctors are certainly not rewarded well enough by the province for the work that they do.
Well, hearing you say a dollar amount of $10.80 on the shot, it
That's
actually
it.
seems a little bit surprising, and it seems to fall short of that. And that's even before that whole breakdown that
Correct.
you're thinking in administrative nuts and bolts of, you
And-
don't just get that flu shot, you get that in a syringe that has come from somewhere and
Correct.
has a cost.
Correct.
And
And one of the things I left out, and I apologize, but one of the things I left out is, doctors today are pretty much not able to navigate without having computers in their offices.
right,
Well, who pays for the computers? Who pays for the connection to the internet? Who pays for the software? And the answer is physicians, not the province. And so I have some clients, and you don't own your software, you rent your software. And I have clients that are paying up to $675 per user per month to rent software so that they can communicate with their patients, so that ultimately patients are in the know about when those flu shots are being delivered. So I kind of missed one of the big steps was, I kind of went through what's involved in getting the actual flu shots into the arms of the Ontarians, but I forgot the fact that there's a huge piece of infrastructure called a medical record, which doctors also have to be able to have in place to communicate when flu shots are being given. And so
Yeah, it's a
by the
big
time,
responsibility.
right, and so by the time the doctors are done giving a flu shot, I would think that their profits are somewhere around $2.50 a shot. That's an awfully low number when when you consider the amount of education, the amount of debt that these young people come out with. It's
Right.
absolutely staggering.
Minimum $20,000 to get their foot in the door of their education.
But that's a very low number. Granted, Canadian students are subsidized for their medical educations, but the average basic fee structure for medical school entry is around $30,000 at the low end, and that's before you buy your books and before you set up shop and pay rent, and so most kids today are graduating with staggering amounts of debt.
And they pave the way easily. I know the banks will say, hey, we will set up a $200,000 line of credit for you if you show that you've gotten into a professional education. And once they do have that line of credit, I mean, that's not mommy and daddy's money. And somebody's going to want that money back. Never mind all the other areas that they actually do need funding.
I don't know, Eva, but I didn't have the kind of mommy and daddy that you're talking about. Maybe you did, but
No, that's Mr. and Mrs. Bank that's willing to.
Mr. and Mrs. Bank, correct. And in your case, probably on Bank Street, but mine was certainly through Mr. and Mrs. Bank as well. So
Right. Well, aside from people meeting with a struggle of their needs through a physician and the physician's ability to deliver that service, then in between the gap is the emergency room. And it was a news item recently that more than 5% of emergency room attendees and visitors, people who are there with true emergency situations, have actually opted to walk out without receiving any medical care whatsoever. And it's a kind of shocking think of it. It's like, oh, well, 5% or so, that's not a whole lot. But when you look at that in terms of human lives, somebody who has been somehow injured or gone through something that needs attention and has been made to wait 6, 7, 8 hours and then left, what do you think is the remedy for that small group of people falling completely between the cracks, and once they're there for the service can't get any?
right. So one is you have to take a look a little bit more globally, which is how much in Emerge is truly acute care, and how much is just patients not being able to access their primary providers. So for things that could be easily managed in the community, why are patients showing up in an acute care center where really and truly an awful lot of things could have been triaged into a community-based practice? But as I said to you when I started my chat, 5 million Canadians don't have access to primary care. So if you get an infection around your nail bed and you need treatment because your thumb is 2 times the size that it should be,
Right.
You're going to emerge. And one could ask, well, gee, is that something that could have been managed in the community? So that's question number one. Question number two is, I don't know if you're aware, but something quite interesting has come about, which is that pharmacies are now allowed to treat, as of October 1st, they're now allowed to treat 16 minor conditions, minor ailments. Well, a lot of my clients have a problem with that. And certainly one of the reasons that the government has allowed for pharmacies to be involved in the treatment is because the shortages are so dire. And when we're talking about minor treatments, They're talking about uncomplicated urinary tract infections, uncomplicated upper respiratory infections. They're talking about things that could have otherwise been managed, in a community-based family practice or setting. I just wonder, um, I am not, I'm not a physician, and I don't profess to be, but I do have an area of expertise. I'm not certain I would be comfortable stepping out of that zone. I'm not certain, first of all, how well equipped are pharmacists to be behaving like physicians? What kind of training have they had? And the other thing is they don't have access to your health records.
No.
So if you show up to your pharmacy with urinary tract infections, how are they going to know what your allergies are? And what happens if you're in a fog and you're not feeling your best? You've got a pharmacist who's treating you without a complete health history and could be adding to some of the chaos that's out there. So, I'm delighted to see that the ministry is trying proactively to do something, but you're asking people who are experts in pharmacology to behave like physicians. I wonder if that has, implications.
Oh, of course. I mean, it's a little bit like the days of the Wild Wild West
Yeah.
when the barber was the dentist, right? And truly, there's no difference in that. It sounded barbaric and ridiculous
Well,
to look
really,
back on.
I think you must have read Sweeney Todd, the Demon Barber of Fleet Street.
Glanced at it.
Yes.
Don't want the nightmares.
Oh, goodness. Anyways, yeah, so
Now,
it's all
these are in a way scary points, right? And
yes.
and it's what's coming here. It's already here. You're delivering a service to professionals who are here with, at great expense, with huge amounts of knowledge. We've watched a gradual change. It's sad to call it again an erosion, but there was a time when the emergency room was sufficient. It was adequate for meeting urgent care compared to what's happened right now.
Yeah.
And in so many different areas, like you can go to a smaller town, you can go to a place where they have a smaller population. And what do you think we need to do to get back to that point, to make the emergency room much more of an adequate situation? Something has changed. What's that change?
So I don't think that you can simply look at the problem at the level of emergency room only. I think you have to kind of filter it from top down. The government has put some very interesting strategies in place that dictate to young physicians what their working hours are. That's very challenging. I think if you look at the statistics, 70% of the graduating class happen to be young women. Well, when young women are off and finish their medical training, they go off and they start their family planning. And in the current physician services agreement, depending on what particular operational model a physician is operating under, there are certain goals, or as the ministry calls it, aspirational goals, that physicians have to maintain. And you're asking physicians to take valuable time away from their families
Right.
to support the health and welfare of other people's families at the cost to their families. And so I think in order to have a return of efficiency in our hospital rooms, we need to take the demand off our hospital rooms. And the way you take the demand off the hospital rooms is that you triage non-acute matters back into the community. The problem is there's no one to triage these patients to, because, as I said, the shortages are so dire and so real. The first thing that I would say to your audience right now is, if you have a doctor currently, don't shop around and try to look for another doctor. That's just going to get you into trouble. The other thing is, if your doctor asks you for certain things, try to comply, because as it stands, if you lose your relationship today with your physician, your chances of replacing that physician are slim to none. And, the other thing is, we're certainly in my endeavors, I'm trying to teach physicians to think about their universe as small business operators. And, coming back to the whole experience in the emergency room, we're not going to be able to reduce that burden until we increase accessibility in the community. And the only way we're going to be able to increase accessibility in the community is by incentivizing young people to stay involved in their craft, to keep them working, to not, to not penalize them for patient behaviors. And I just want to come to this point, which is, and I'll come back again to your question about the demand on hospital emergency departments. Under the current model of remuneration, family physicians are penalized if their patients go to a walk-in clinic.
Right.
So they actually pay whatever the doctor bills into OHIP or into the provincial payment plan, whatever that doctor bills, your family physician has that amount deducted from their monthly salary. And so we're talking not about patient accountability, we're talking about physician accountability. So we've got physicians that are penalized for patient behaviors. As part of the physician's payment structure, there is a very small component of their salary that's tied to performance benchmarks. So if a physician has, let's say, 300 patients in their primary reproductive years and they need a pap test, and your patient declines the pap test or simply doesn't come into the office to receive their pap test, the doctors are penalized.
Really?
Yes.
Really?
Yeah. Yes.
Well, people might have different reasons for declining certain procedures and treatments.
They might, but in Ontario, this is how our remuneration model works. And so it's based on performance benchmarks. And there's no penalty for patients going to walk-in clinics. There's a penalty to your family doctor.
Right.
There's no penalty for a patient not getting a colorectal screen or getting a breast screen or a mammogram or a pap test. The doctors are penalized financially. And so
But it's sounding a little bit like, you go into a bistro and everyone's trying to push the chicken salad and the chocolate cake. And the whole reason is the manager at the back says, hey, we're pushing chicken salad and chocolate cake today. And you don't know if someone has a chicken salad allergy. If someone, for different reasons, maybe they have some emotional reasons, maybe they have some bad memories and they're bypassing taking a pap test. It might seem unreasonable, but it is their own experience is drawing them away from certain procedures. And to have your doctor penalized for a person going through a decision-making process in their own treatment is it's heartbreaking to hear it broken down that way, especially when it almost seems like there is a menu for your healthcare. Stick to the menu.
correct, and they're also penalized for for anti-vaxxers. And again, you have to respect people's decision to make choices. There's no question. But why penalize your primary provider? They're already penalized enough, to be very honest with you. They're paying 40 to 50 to 60% of their gross earnings for infrastructure. And, quite honestly, there was a study published very recently, and please forgive me, Eva, maybe you can take a look at that study, but it says that in order to live, not comfortably, but to attempt to live in the GTA, you need a minimum of about $40 an hour to support the demands of your life. Well, I can tell you there are no medical office administrators that I know of that are making $40 an hour. They're lucky if they get $22 an hour or they get above minimum wage. And when doctors wonder why their staff are late coming to work, it's because they're taking an hour GO train from Pickering or Oshawa or Burlington to try to get into Toronto. And it's absolutely maddening to increase the demand. And just the cherry on top is your most important second most important component of a medical office is the gatekeeper. And to have dissatisfied gatekeepers because you can't afford to pay them properly is very, very sad.
Well,
And so,
truly, it's, to switch that to the administrative side of it, which it's a partnership, right? They are, you're right, gatekeepers. They are bringing in or not bringing in whoever they're communicating with, well or not well. And having the right kind of person as a gatekeeper in a medical facility or medical office is so important. It's an interesting view and very insightful. I'm loving every scrap of this. Right now, we're going to take a break. We're going to talk about our sponsors and supporters, and we'll be right back. Cool Life Podcast.
thank you.
Those lonely days of lockdowns and isolation are gone for good. Go to www.therealthingdating.com. That's www.therealthingdating.com. It's time to share. Share your time, share your life, share your love. www.therealthingdating.com. Join for free. Upgrade at any time, starting at just $5.99 a month. www.therealthingdating.com. Because it's time. You're listening to the Cool Life Podcast. We'll be back in 3, 2, 1. And we are back at Cool Life Podcast. I'm Eva John, continuing our conversation with Jeffrey Gelgoot, President of Gelgoot Healthcare Consulting. Jeffrey, in the 20 years that your company has been in existence, you've evolved to a premier healthcare management consulting company. You speak the language of doctors. You help them through that all-important transition from simply knowing how to be a great practitioner to becoming an administrator, which is become a key part of delivering service. Why do you think it has become so important, almost more important, to be an administrator as a doctor operating in Ontario today?
Um, it's a great question, Eva. I think that the reality of being a doctor in this province and being in the community is that community-based providers are small business operators, and they have to take on the role of business operators, whether they want to or not. They have to throw themselves into the ring. They have to know how to negotiate leases, how to buy contracts, how to do payroll, how to do HST remittances, how to do source deductions. It's a major responsibility. And to be very honest with you, I've never had a client step forth and say, geez, it would have been really nice to have kind of a business 101 thrown into our medical school so that we knew what we were walking into, or at least had an idea of how to do this and how to do it safely.
In law
And so,
school, it does happen. Lawyers, before they go out and hang their shingle and hit the bricks, they actually do get an administrative course, and they get a follow-up inspection that's a part of maintaining their license,
yeah.
that to make sure that they're dotting their I's and crossing their T's, their files are inspected. And it seems like an inspection, but it's also support to make sure they're not going off the rails. And there doesn't seem to be a parallel for physicians, is there?
Well, I'm not sure you'd call it a parallel. I mean, there is a regulatory body that kind of helps, but they've shifted the way that they in quotes help. They still respond to patient complaints, but they've moved a little bit more to the right, and they're doing quality assurance, quality insurance studies now, which are self-reviews, and they help physicians kind of understand the metrics of their practices, not on the business side, but on the medical side and the measured
Right.
patient outcome side. Um, I wouldn't say that they're in quotes there to help, um, but they're there, and they're a worry for most physicians because the public still has the ability to make a bit of fuss. And I'll just give you an example of a friend of mine and a client. And so that complaint got to the college, and ultimately that complaint went back to a client of mine. And um, that is so disturbing for a physician to receive a complaint like that. Remember, everything we spoke about in segment one is you're in the community, you're paying your own rent, you're supplying soap and toilet tissue. Let the patient use a public washroom and not worry about the fragrance of the physician's soap. And then, lodge a complaint to the college because the the soap was too floral. Oh my goodness, what are we coming to? And so um, this can all tie back to experiences in the emergency room. If young doctors know that they're at risk of getting a complaint because the soap that they put out you know, in their washroom is objectionable to a handful of patients, and they think that they're going to get a complaint, why would anybody enter a discipline where they're at risk of somebody, launching a complaint against them? And so if you look at this in kind of layers, we have a shortage of doctors, we have a shortage of emergency room doctors, we have an abundance of patients, and we have shortages, shortages, shortages. And if you wonder why, it's, you know, it's pretty apparent, and there's multiple levels of why we have such shortages. But
But the
mostly,
situation that you've mentioned, I mean, we live in a more litigious society.
yes.
People really every year it seems to become a stronger option that I guess for some people it's kind of their lottery ticket, it's their ride, that they can get a foothold on something, and it's not a put down to something. I mean, if it's going to succeed in court, it's going to succeed in court, no
Mhm.
matter who has an opinion on it. That if somebody is going to take those steps, then and say that this doctor, aside from getting straight A's through medical school, is now responsible for your reaction in a washroom, and you're treating this as if you have an opportunity to sue the city. You're not suing the city, you're attacking the career of one individual who has
Right.
struggled through years of a very difficult education to deliver a service, which has now become a non-issue because somebody is focusing on their personal experience in a washroom.
Yeah.
It is a little scary that it could boil down to
It's
something like this.
correct.
Can I hope there was any type of a happy outcome in the end, or is it going on
Yeah,
still?
I mean, I think ultimately it was just dealt with quite locally, and it was dismissed and managed appropriately. But I think patients at times can take too many liberties. I think people need to understand that healthcare is not free. I am a huge proponent of a copay. Put a jar in a doctor's waiting room, put a loonie in there, put that loonie back into the public system. That might mitigate some of the stuff that shows up. And by doing that, you free up available space so that doctors can manage non acute issues. And when they're managing non acute issues, those are the things that are ending up in hospital emergency departments. And then the other thing is, I wonder if we introduced a $2 copay in the emergency room, would that mitigate some of the unnecessary stuff that's coming through the door? And again, the copay goes right back into the system, but I'm just speaking out loud. I'm just saying, hey, are these things that that
But it's something that could offer a solution and a little bit of help and ease certain stresses on the
yeah,
system, but it could also alienate a lot of people.
yeah, yeah.
It's that's a risky thing. Now, Jeffrey, I want to get your take on this. Healthcare pre-pandemic,
Oh,
healthcare post-pandemic.
right, right.
This was, I mean, yeah, they say, oh, we haven't seen anything like this for 100 years. No, we haven't seen anything like this because the conditions 100 years ago were so distinctly different from what we're encountering here in Canada, from what people were encountering in the United States, as far as recovering from, and I guess we're still in a recovery from
Right.
the pandemic. What do you see as those differences, pre-pandemic healthcare, post-pandemic healthcare?
So, um, I have lost 160 of my clients to retirement, and when I say retirement, I'm talking about early retirement. That were, if you remove the pandemic, I'm talking about young men and women in their 30s and 40s who walked away from the profession.
Mm-hmm.
And part of it was just the stresses and the demands. And the other part was patients who were very impatient and who were very disrespectful at times and that were making demands on physicians that could not be met. And so, if you look at the statistics, which I don't have in front of me, but Ontario has never seen numbers as high as they've been in terms of people who've left the profession. My youngest was a 29-year-old. 29 years old. She'd been in the field for what, 4 years?
Well,
She just
congratulations. It's amazing.
No, it's not amazing. I'm talking about a 29-year-old retiring from family practice. That's absolutely terrible.
Okay. Well,
She
yeah,
couldn't deal with the stressors
right.
and was sad.
My congratulations. I'm amazed that she was there. And I think that's a
Yes.
huge achievement to feel very proud of on your part, on her part. And it warms my heart to know that it's a lot to go through to get
Mm.
there. I'd like to think that the story is still, as they say, unwritten. Um, you know, in the end, it's not how you start, it's how you finish.
Yeah,
And I hope there's a way
sure.
back.
I hope so. I hope so. I was kind of dreaming off and thinking about all these incredible talents who gave up their patient populations. And wouldn't it be lovely if they came back to work someday? Such bright, talented people who were victims of the system, who are victims of the system, who were really mistreated. And I think it's really important that the average Ontario user is respectful towards their doctor, recognizes that, yes, this is their job, this is their chosen profession, but their work is grueling work. Um, it's it's challenging. The average Ontario citizen will go in and get a haircut and they'll tip their barber $5 for a haircut. Or if they have their home cleaned, they'll tip the lady cleaning their home. Or if you have some renovations done, you pay for this. Or lots of people buy a case of beer, and people don't appreciate their doctors in that way, in part because it's discouraged, but whoever thanks their doctor for a cancer diagnosis, you know? They just don't.
Right. No, they don't.
They just don't.
It's
But
good to know that there's treatment and action to be taken.
and
But
and
yeah,
thankfully that doctor found your cancer. It's like without it, you know. So they have a hard role to play. It's in many ways a thankless job.
yeah.
And people think that they know that going into it and they shouldn't be waiting for thanks. But I think that we can do a better job as Ontarians using that system. When my son broke his arm and we were at the fracture clinic for weeks, oh my goodness, 6 weeks, 7 weeks, 8 weeks,
Oh my.
I would go to Tim Hortons, and not everybody can do this, but I picked up a large case of coffee and I picked up 2 dozen Timbits, and I spent $20 a week. And every time I went to that fracture clinic, I made certain that the girls behind the desk who were supporting my son had a cup of coffee and a donut. And they were so grateful. And it didn't mean that I was getting better service or faster service. It just meant that I was very appreciative for the services that we were getting.
Well, and it's a beautiful reminder that, leading by example, that you're taking some time out of your day and putting some skin in the game to say you
Absolutely.
appreciate the work being done, important work being done.
Yep.
So
Absolutely.
well, and it's given me something to think about on how have I been treating my medical practitioners and their supporting staff. So there have been enhancements, through basically every type of industry using technology. Do you feel that the use of technology and the support to technology, AI, robotics, have affected the grassroots of medical practice?
Very much so, in both a very positive and very negative way. I'm very grateful, and I was here for the transition from paper-based offices to electronic medical record keeping systems. But the systems don't talk to each other. So that's a huge obstacle. And what could have happened, should have happened, was that the provincial government, who basically was in charge of these various programs, probably should have handed the doctors their computers with their software and said, here you go. And that didn't happen. And even within hospitals, you have 4 or 5 different electronic medical record keeping systems. And so if you have an inpatient and you want to get some results from radiology, you don't necessarily connect because they may not be on the same system.
Wow, really?
Mm-hmm.
Okay.
It's not an ideal system. And then again, there are some users that are very happy that things aren't that accessible to one another because they feel that there's the potential for misuse.
Oh,
I don't see
well,
that.
how so? Like that if it was a universal system and if all the information was easily and readily available, translated across all different areas of the medical support, that how would that be misused, do you think?
Well, if you remember back to 6 years ago with the late Mr. Ford,
Right?
he had some kind of very aggressive cancerous malignancy, bone cancer, if I remember correctly. And there were some people in one of the divisions of the hospital who wanted to check out the records of this very famous politician, and they did. I don't know if you remember that, but there was a fundamental breach there.
Wow. So that's something where I think basically any type of customer service situation, there's rules in place, and someone breaking those rules, looking and seeking out the records of a famous person, whether that's because of their very private medical care, or if it's because it's their lawn care. They're still not meant to access that, say, oh, well, I know that so-and-so's cottage and we take care of all the gravel in his driveway. It's like, they aren't meant to entertain themselves with customer records. And it's pretty sad to know that happened. I think that the gentleman had more than enough turmoil and concern in his life. So, Jeffrey, in the 20 years that you've had this version of your company offering truly top-notch support to medical practitioners, to physicians for their administration and healthcare consulting. We have seen change and growth in Ontario, across Canada, and a look back from then until now. It's easy to say there's been a deterioration. Do you feel that in these 20 years, from the Ontario that you witnessed when you started supporting doctors as an independent consultant to the Ontario you're seeing now, have we taken a step backwards in the service we're delivering?
So I think that's too broad a question. I don't think that the services that Ontarians are receiving is subpar or suboptimal. I think what's happened is that the people who are delivering those services are feeling very overwhelmed with the pressures of the demands of the system, the demands of difficult patients. And so I think that in some ways there has been some deterioration in the kind of respectful order that should have been restored. You know, I'm in doctors' offices daily, and I'm still very respectful of the fact that these folks are my clients, and when I'm with them in a public setting, I never call them by their first names. I'm always very respectful that they've earned their titles. But I sit sometimes in a waiting room and I'll see a patient saying, "Hey Rick, how you doing?" And you know what? It's not Dr. Rick, it's Dr. Smith. And I think that it's small and it's silly, and it doesn't necessarily shape the framework of the relationship. But there has to be a return of a kind of a good old fashioned ethic of the hierarchy in that relationship. Rick is not your friend. Dr. Smith is the person who is cheering for you, rooting for you, advocating for you. And I think doctors are feeling a bit of a lack of respect,
Oh,
both by their government and by their users. And I think it's up to us to pay attention. You know, some of my clients have started to charge these user fees, block fees, uninsured service fees. They charge, I don't know, $75 or $100 a year. I happen to think it's very important that if people can afford to pay that, that they pay it. I think it's important. I think it shows your doctor that you have trust in the relationship, you have faith in the relationship. The fee is never meant to create any hardship for anybody. So
right.
clearly patients on ODB or on any form of disability or any form of kind of secondary support, they're not subject to it. But those fees are there to help the doctors maintain the infrastructure. And, you know, sometimes I scratch my head and I think, well, holy smokes, if the doctor's asking you for $100 a year, it's $8.25 a month. You know, he's asking for it not to get rich. He's asking for it to help him or her defray their infrastructure, their overhead costs. I would encourage Ontarians to think about that fee. I think it does have an impact on the relationship. You know.
Definitely. It can, because even that example from the flu shot that you gave,
Yes.
it's pretty shocking to boil it down to the fact that a doctor is probably in fast competition with the paper boy
Yeah.
for
Well,
what they're earning for the paper boy to deliver a paper and for the doctor to deliver a few
so,
flu shots.
so I'd like to give you an example, and I hope I'm not straying too far from where we need to be, but most Ontario doctors in family practice are paid via a capitation model or a blended capitation model. And of course, a per capita payment means per head.
Right.
And the per head payments are age and sex adjusted. So just let me give you an example. A 16-year-old male patient on a physician's roster or patient list pays that doctor $68 a year. Whether that patient comes once or whether that patient comes 25 times, it's $68. And if that patient goes to one walk-in clinic, $37 is deducted from the doctor's $68. If he
Wow.
goes twice, if the patient goes twice, the doctor has lost his entire salary for the year.
And
in
there's
I
different reasons why that might make sense to use a walk-in clinic, right?
Sure.
You take your child to a basketball game against a school in a different area, and they
Yeah.
jam their finger on the basketball,
Yeah,
and
for sure.
they're writhing in pain, and you just don't want to make them wait any longer, and you go
For
to
sure.
a nearby walk-in clinic, not realizing the domino effect.
Well, except that under these new models, doctors are meant to allocate a certain amount of telephone time to their day. So
Right.
if a mother calls a clinic and she's in distress, it would be certainly reasonable to think that within a couple of hours of that distress, that somebody from the network could get back to the mom and give her instructions on what to do.
Right.
So anyway, it's a catch-22.
It's a catch-22, but it's like, we're not talking about ice cream service, and
No,
we're not talking about a dog walking service, as important as that is for
no,
some
for
of the
sure.
people in this room. But the fact is, we're talking about a service that can directly affect your quality of life, directly affect the length of your life.
Yes.
And I think it certainly needs more support than that.
Yeah,
Now,
absolutely.
globally, as far as what you've encountered, your knowledge over the years, your experience with different types of physicians, what would you say is the model of the best delivery of healthcare that you feel should be mirrored from, and just like basically anywhere in the world that you're aware of? What do you think is the best?
Well, that's complicated because it has to be a kind of a hybridized approach. But the first thing is we have to stop penalizing doctors for their patients' bad habits. And then part two is there has to be more and more of an investment in mental health. In these models, mental health is very much excluded from the doctor's salary. And with the amount of supportive care that people need, they're just not getting it. And good luck trying to get a psychiatrist in the province right now. But family physicians are somewhat trained, not hugely trained, but they are trained. If a patient is having an acute moment, that they can support them through a crisis, but they certainly don't get paid for that support. They simply don't get paid for it.
And it's it's really kind of scary if you think about it. The need is there, and
Yeah.
it's just not structured to offer a reward for doing
Yeah.
that work.
Stay home, be safe, be healthy. Don't go to the doctor. Don't go to the hospital. I mean, just stay healthy. That's keep your screenings up to date, and maybe a little bit of investment in health promotion. I mean, you'd be very hard pressed to go into a grade school and speak to grade 2 or 3 students about what a carbohydrate is or what a protein is. You still see dispensing machines in those school cafeterias with Orange Crush and Coca-Cola. Those are big problems.
They're big problems, but I mean, there's always those who will say, well, we made it through the 70s with those just fine. Not a good food group in a single meal all day. And we know that we know better, so we'd like to do better. And that's the answer there. So for the moment, we're going to take a break to once again talk about our sponsors and supporters, and we'll be back on Cool Life Podcast. Those lonely days of lockdowns and isolation are gone for good. Go to www.therealthingdating.com. That's www.therealthingdating.com. It's time to share. Share your time, share your life, share your love. www.therealthingdating.com. therealthingdating.com. Join for free. Upgrade at any time, starting at just $5.99 a month. www.therealthingdating.com. Because it's time. This is Cool Life Podcast. Please remember to subscribe to Cool Life on your streaming service and on YouTube as Hellenique Today. That's HELENIQUE Today. Because that helps us to bring more cool stuff to your ears. You're listening to the Cool Life Podcast. We'll be right back. And we are back at Cool Life Podcast. I'm Eva John, and we are continuing our conversation with Jeffrey Gelgoot, president of Gelgoot Healthcare Consulting. And Jeffrey, in the medical profession, there is a big, scary word, malpractice. Do you feel that the service that you deliver to physicians who are taking your administrative consultancy, you think that you're helping to protect them and enhance their abilities to function without as much concern for issues of malpractice?
The most that I'm prepared to say to you is I will never put a physician in harm's way, ever, by advice that I offer. And so, there's many, many reasons that a doctor can find themselves in, under the guise of the Royal College for malpractice. There's behavioral issues, there's sexual misconduct, there's procedural issues, there's billing issues. I work on the billing and management side of things, and so the work that I do simply enhances what's in the schedule of benefits, and I don't teach doctors how to push buttons in their computers to bill for things that they haven't done. So that's my answer, basically.
And so, with you having so much knowledge, experience, so much constant interaction with doctors, have you ever felt that you had wanted to be a doctor yourself?
It wasn't an option. You have to have the DNA for it. I think people are born with an innate ability to survive the rigorous course loads, and I definitely don't have the DNA.
I certainly think that you would make a heck of a doctor, my opinion.
Okay. Well,
Now, if there were no issues of budget, if we could just wave a magic wand and just say, this is what needs to be done, this is the fix, do you feel that in the capacity of a politician, if you were going in that route, do you feel that you would be able to identify and restructure for the better the system we see in Ontario?
Yeah, I mean, that's such a complicated question, Eva, with so many layers. I mean, truly, the codependency, the interdependency from one discipline to the next is so widespread. It's just too complicated to tackle. But the system is very cracked. It's very, very broken, and some very, very basic fundamental systems are not working.
That's a kind of a harsh assessment. Like, I know that it's based on fact and what you've experienced, and we still remain a leader globally in our delivery of healthcare. It's just we've seen better days, truly.
The system has seen better days, and some sage guides or teachers of mine, have stopped using the expression that healthcare's on life supports. They now have told me that the ship has sunk.
That is an unfortunate assessment. I'd like to somehow remain hopeful as long as we've got people like you in our corner.
Thank you.
No, for sure.
If it was only that simple. There's still opportunities to treat it like a business and to do your best. But certainly, if your primary motivation is to have a well-balanced life with a decent, steady paycheck, forget it. That's not what this discipline is going to give you.
Well, I don't think there was ever a time in history when being a doctor, except maybe being a country doctor, could offer that kind of peace, quiet, and stability, and, and an easygoing schedule with family time. Maybe in a small town of 1,800 people, maybe, right?
Maybe.
And so, as far as final thoughts, are there causes that are near and dear to your heart that your work has been able to bring you closer to achieving?
Absolutely. You know, my goal is always to improve outcomes, measured outcomes. So, you know, if I go into a client's office, you know, where are there areas of improvement that we can focus in on? You know, using the tools that are available. Um, you know, what can we do to use those tools to enhance the physician's experience, the patient's experience, everybody's experience? And that's what I usually take on. And big or small, I think that it can be a win-win situation for sure.
Well, Jeffrey, it's certainly been an exciting adventure getting a closer look at your first-hand experience working with doctors, the improvements that you see that are in need. You're certainly welcome anytime to shed some more light on this complicated issue. For now, I want to thank you for your time.
Thank
for
you.
your intelligent, wonderful, insightful view of healthcare today.
Well, thank you so much, Eva. It's always a pleasure. Keep smiling.
My pleasure, for sure. Thank you. Bye
Thank
for
you so
now
much.
from
Okay,
Cool
bye for
Life
now.
Podcast.
And that was our show. Thank you for listening to the very end. Please remember to subscribe through your streaming service to get more access to our guest interviews. Also, please subscribe on YouTube to help support our podcast. Until next time, I'm Eva John for Cool Life Podcast. Thank you for turning me on.